Well, thank you very much. I'm very happy to be back with you. It's been a long time since I've been at the round table, and I'm always happy to see old friends and make new ones. I'm here on behalf of a team of people that I will introduce in just a minute, but I wanted to open with a thought that came out as a result of a conversation yesterday. So I was talking to someone about the paper, and he said, okay, give me the really big idea here. He said, I've read the paper, I've read your conclusions, but what's the really big idea here? And I think in plain language, the really big idea is that there are a lot of people looking seriously at communities that are in need and trying to do something to help those communities get better information, build their skills and whatnot. Now, that being said, we know that good intentions are not enough. We're here to discuss other things such as the science, the rigor of the design, whether those were the right interventions and whatnot. But I do think that we opened the discussion section of the paper intentionally to give you a sense of the richness of what we found in the literature, and we hope that that is not necessarily discouraging in terms of maybe some of the quality or scientific issues in the papers, but more stimulating where to look forward. So with that, I will begin my formal presentation. So I am here to present an overview of our community-based health literacy interventions review paper that we've conducted over the last several months. And the team consisted of myself, Dr. Lourdes Martinez from the Centers for Disease Control and Prevention, who's here today. Dr. Martinez, do you want to make everyone know? A librarian from the University of Maryland, Nedalina Changalova, who is not with us today, but was a very integral part of the team, and Dr. Don Rubin from the University of Georgia, who's joining us by webinar today. And I also want to acknowledge two other CDC colleagues who were instrumental in helping us choose an evaluation framework. Tom Chappell, who is CDC's lead evaluator, and Dr. Doan Arolu, who is CDC's lead health communication scientist. Dr. Alice Horowitz from the Horowitz Center was an important reader and commenter on the work that we did, and the Horowitz Center graduate student Heather Platter. So I want to open and close with the same set of questions. And these questions were the ones that weren't necessarily stated in the call for proposals, but emerged very quickly as we started looking at the literature. And they're questions that we didn't fully answer as a team. They're questions that occurred to us, that we grappled with, but we felt like it was important to bring these questions to you all for further discussions. And so the first question then is, what does it mean to take a community seriously? And by that we mean something more than a location. Because when we looked at a lot of prior work on community interventions, a lot of them began with a location. And we know that community has a much richer and broader meaning than just a location. But a lot of the interventions, that was indeed their starting place. The second question we had is, what distinguishes a health literacy intervention from an educational intervention? We had to sort through a lot of educational interventions to try and find things that said they were in some way, shape, or form trying to grapple with health literacy. And I'm happy to talk more about that, and I imagine it will be an ongoing topic throughout today's discussion. And the third question is, what is or could be the value-added element of doing a health literacy intervention? So there is, a companion set of colleagues in field, if you will, about community interventions. And we also had to sort through a lot of those. Community interventions that were focused on knowledge and skill building related to specific health concerns or health topics. But what does health literacy bring to that work? And that's frankly a question that I continually poked my CDC colleagues about. Because as an agency, as do many other federal agencies, we made a huge investment in community-based work. And oftentimes the health literacy issues were not necessarily obvious to the funders, to the program planners, to the evaluators and whatnot. And so we think that there's a valuable discussion to be had about all of this work that goes under the rubric of community intervention. What could health literacy bring to that, and how do we as a field help articulate that and increase the rigor and robustness of that work? So on to the review itself. So I thought I would open with an example, a story of one of the two projects that we found that showed the largest effect sizes, because we were asked to look at that in the review. So this is from a study by Hernandez and Organista, published in 2013. It was based on a photonovela developed by Dr. Cabasa at the Columbia School of Social Work. And its intended outcomes were depression literacy, increasing depression literacy, decreasing stigma, and increasing help-seeking knowledge and behaviors. They used social cognitive theory and culture-centric narratives, and they used David Baker's health literacy definition from 2006. So the intervention itself was this photonovela with, as you can see, with the photos and the bubble dialogue that was culturally familiar and appealing format. And they labeled this their health literacy tool. So the photonovela was the health literacy tool. So either one arm got that or the other arm got a group discussion about family communication issues. And these group sessions were led by promotoras in a local community clinic for Latinas who were identified as low health literacy, and there were 142 Latinas in the study. It was a pre-test, post-test, a randomized control group experimental design, and their measures and results were as follows. So it was on depression knowledge, where they showed a large effect, stigma, moderate, self-efficacy to seek treatment, large, intent to seek treatment, moderate, depression, they just had a score, they had a depression scale, and they used the S-TOFLA, and so they had a health literacy score. They did not do a pre-post on that. But this gives you a flavor, like sort of a quick in-depth look at one of the two projects that we found that because of the design, we were able to report on the magnitude of the effects. So I will go on to the broader findings and conclusions then for the whole body of work that we looked at. So we found a very wide range of interventions, and the results table that's part of the paper gives you a sense of that range. There's a mix of qualitative and quantitative evidence with more emphasis on the qualitative evidence. Health literacy and community were terms that we saw frequently. They were the terms that we searched on in the review, but they were often not well explained. They were invoked, they were used, but they were often not well explained. And one of the things that kind of emerged, I guess, organically from the review is that we saw that there was a pattern in the way that health literacy was used in interventions. First of all, people said they selected people for the intervention based on either assumed low health literacy or documented low health literacy. They tried to measure something about health literacy in the evaluation. So they might use the tools that we're familiar with, like the RELM or the TOFLA or the newest vital sign or the screening questions from Lisa Chu's group, or they might create their own scales. We saw a range of things. They would use health literacy techniques or principles like we saw with the photonovela, and so it would inform the content or the actual choice of what the intervention was going to be. So health literacy would help shape what the actual intervention was. And then oftentimes we would see health literacy stated as the outcome, right? So they were trying to increase health literacy or improve health literacy, or something about health literacy was part of the outcome, whether the sole outcome or the main outcome. And that was not a framework that we had to start with. Again, it was something that we labeled a finding because we saw it consistently as a pattern across the interventions. And then the final point is that because we were asked to look at the quality of the evidence, not do a full-blown quality analysis, but to the extent that we could, we saw that in order to make sort of more informed comments about the scientific rigor of the study design and whatnot, what can and should improve. So I want to begin with this notion of community, what it means, and the fact that it was, as people like to say, a moving target within the work that we looked at. So we used a paper that was published, it was an editorial published as part of a broad community-based review that said that community can really have four meanings. It can be a setting, as I've talked about. It can also be a target, as I've talked about, the population or the group that you're trying to reach with your intervention. It can also be a resource, like what about that community, what are that, more of an asset perspective, I guess is the way to think about it. And then the fourth one, which is sort of, if you think about them as a hierarchy, would be the most fully developed, most engaged, would be as an agent, where the community is really engaged in whatever the issue is that they're being asked to consider. So what we saw in the papers was really a lot of the first two, that people talked about the settings that they used. So for example, people would talk about community hospitals or community clinics or community agencies without necessarily defining what the community element was. Or they would say they would recruit from the community, right? Or they had community participants, but again, without necessarily defining what were the boundaries of this community that they were considering. Was it defined by language? Was it defined by shared experience? Was it, defined by some combination of factors? So community was very challenging, and given that our charge was to find and talk about community-based health literacy interventions, we really had to grapple with this concept throughout the whole review process. So a little bit about our methods. I again want to acknowledge how important having a professional librarian as part of our team was in this process. Really helped us stay on the path of rigor, I think. So we did what is called a scoping review, and what the purpose of a scoping review is to sort of identify a broad area to give you sort of the lay of the land, I guess is one way to think about it. You can have different study designs, and you're trying to map key concepts, sources, and types of evidence, which is what we tried to do in the paper. This is to distinguish it from a systematic review, which is, got much tighter definitions about the kinds of studies they will consider, and much more focused on analyzing the quality of the evidence. You can do a scoping review as a prelude to doing a systematic review, and that might be one thing that you could talk about is, would you want to use this as a launching pad for doing a systematic review, sort of like a community guide style type review. So we conducted the literature search as we explained in the paper, and we provided our search strategy as well as the databases. I think we're going to give ourselves a gold star. I don't know too many reviews that used 14 databases to search for the literature. And we, as directed in the call for proposals, we chose an evaluation framework, which I'm happy to talk more about. It's known as the CDC Best Practices Framework, and it's a framework intended to look at applied public health interventions and analyze them based on 5 dimensions. I'm happy to talk a little bit about that framework and how it worked. So we did multiple rounds of paper review, first title and abstract, then full text. We used this modified best practices framework, and then we created the reporting categories and the synthesis that you saw in the narrative. So we constructed this search, again, based on these commercial databases. We also did a gray literature search, and health literacy and community, along with the other terms in the paper, were defined our search, and our inclusion and exclusion criteria. Inclusion, published in English, although not obviously just in English-speaking countries. They had to be published after the dates of the prior reviews that we were directed to consider. So that was the last one being the Agency for Healthcare Research and Quality Evidence-Based Review, published in 2011. We stuck to peer-reviewed articles except for the gray literature search. So we do have quite a few dissertations in the mix. We even, Dr. Martinez and I even debated including a paper that our librarian found that reported on the use of Sunday church bulletins as a delivery mechanism for health information. They had to have some kind of community sample, and health literacy and community had to be terms that were used in the abstract. So we had to exclude a lot of things, though, because as you saw, we came up with over 2,400 articles. And so there was a lot of formative research there, a lot of associational studies that I know that you've talked about in the past. Again, if they just used a community location, so what they would do is they'd say, well, we used a community clinic, but really all they did was recruit people from the clinic, but then it was an individual intervention. There was no sort of group interaction at all. There was no intent to say anything about the community. That was a cause for exclusion. We did use the reference list from review articles, but we did not use the review articles themselves. And anything that was sort of a model or questionnaire development was also excluded. So our best practices framework, as I said, had these 5 categories on effectiveness, reach, feasibility, sustainability, and transferability. And in the paper, we talk about that this is really more of an aspirational framework at this point, not so much. We did not find a lot of information about the last 3 categories in the papers. We found a little bit about effectiveness, some about reach, but very little about feasibility, sustainability, and transferability, which of course would be important topics, I think, when we start thinking about how do you take a one-off intervention and think about it making a long-term difference in a community or taking it into different communities. So our results, we have found 2,402 non-duplicate records out of these databases. We ended up with 74 papers after we went through the process that we detail in the paper. So we started with that title and abstract review, applying our inclusion-exclusion criteria. We had 170 papers after that. That's what we pulled the full text on. The full text review indicated that there was a lot of this kind of superficial use of health literacy in the abstracts, but when you actually got into the paper, there was little to no use of health literacy in the intervention itself. So we got down to the final 74 that reported the outcomes that I'll talk about on the next screen. And as I said, we found only 2 papers that reported large magnitude of effects. The first one that I just talked about, the secret feelings on knowledge and self-efficacy for depression, and the second one was a cancer screening program. So in the paper, these were the categories that we used to organize the results, and we started from the most general and went down sort of in order, but we did put policy and system at the end, not because we thought it was the least important, but because we only found 1 paper that we put in that category. So we had quite a few on health literacy skill and capacity building, most from outside the United States. Then we had a few on information seeking, a lot led by librarians who were trying to build people's information seeking skills. We had several that said their purpose was specifically to create culturally sensitive or culturally targeted interventions, so we felt that was an important category to use, although cultural sensitivity did come up in studies that we reported in these other categories, and we tried to cross-reference as much as possible in our narrative. We found a handful of studies that looked at adult learners typically enrolled in a formal program through an adult literacy program or at a community college. There were a handful using Head Start programs, and I know we'll hear more about that later today. Again, a handful in schools, maybe not as many as you might have expected, but I think schools are complicated institutions. They're not always that easy to use as a site of intervention, even though they might seem like an obvious place to do a health literacy intervention. We created this other category where we had just 1 study that didn't really seem to fit these other groups. We had quite a few on chronic disease focused on on diabetes and cardiac health issues. We did decide to include mental health. So we're aware that other people who've done reviews in this area did not decide to include mental health as a topic, but we felt the sheer number of interventions about mental health meant that that was an important topic for the field to take a look at and at least consider. Because again, we felt like if there are researchers in other fields, researchers or practitioners in other fields invoking the term of health literacy, talking about what they do as health literacy, even if it doesn't mean the same thing as the group of people in this room today or people listening through the webinar, it's still worth considering what they mean, what we mean, and sort of how do we engage with that. So we didn't want to sort of set that aside and not let you all consider what that means. We found, again, a handful of studies looking at medicine use and health literacy issues, cancer, again, about a handful of studies, 2 on environmental health that were interesting because they were more about engaging an entire community in the process, but the intervention itself was focused on individuals. So, for example, it was a case of individuals testing their own water, for example, but it was a community engagement process. And then one, as I said, on a policy system change. If I recall correctly, it was in Sweden, and it was a national health policy change that was supposed to have implications for health literacy, but it wasn't a health literacy specific policy. So this is the range of outcomes that we found in the study, and again, I tried to order them from sort of what people tend to think of sort of easiest to most difficult, easiest being satisfaction, through knowledge, understanding, awareness, right? Sort of that whole cluster that we found very frequently in most of the papers. Also self-efficacy. Then somewhat, I would say moderately common, were intentions, attitudes, beliefs, self-management tasks, health goals, setting health goals, trying to achieve health goals. Then you start to get into less frequent, the health behaviors themselves, decision-making, information seeking. Again, most of those were concentrated with the kind of librarian-based studies. Only a couple on health services use, one on that self-care model that we found in the UK. Also that policy change that I mentioned from Sweden. Both of those were focused on people's use of healthcare services. Some that measured physical changes, and then some that just said they were trying to measure health literacy generally, and that could be through a range of mechanisms. So in our paper, these were the 4 kind of themes that emerged from our review. We talked about really the sort of positive signs that we saw for community engagement, that virtually all the studies, in fact, I can't really think of one where they didn't try and do, at least some of their intervention had a community engagement component, whether they did a lot of formative research to find out what the community needed, or they used formative research to develop the intervention, or they, again, took seriously that there were health literacy issues in a community, but there was strong community engagement in the descriptions that we saw. There was this health literacy intervention component that I mentioned, that 4-part of choosing the community, using the measures, having the outcomes, or using health literacy in the content design, right? So that emerged from the review. We talk some about the role of knowledge and the fact that knowledge is often disparaged as kind of not a very helpful or not even necessarily all that related to health literacy. But we do point to a few papers that have made that link between health knowledge and health literacy. And we also make the point that, if you want to think about these higher level skills, it's hard to think about getting there if you're dealing with communities where knowledge about the topic is very low. And as we know, virtually all of these interventions started with communities where the knowledge was very low. And then we do talk about the limitations of the evaluation framework. As I said, part of it may be that, we found studies published in a very wide range of journals. That might speak to the standards of different journals or what they expect, the level of detail that they expect in a paper. But I think the evaluation framework is a useful tool to think with going forward about what we would like to see reported about health literacy interventions. I think there's a lot more information that people should be providing to all of us about what they're doing, to not just for the sake of transparency, but also I think to just really understand how are these effects that they're reporting happening. A lot of that was really sort of behind the curtain, if you will, in the papers. So I come back to our opening questions because, as I said, these were the questions that we grappled with throughout our process. I've given you a little bit of flavor of our thinking about community and how we tried to, kind of wrestle that down to some manageable form during our process. But I don't think that we have a hard and fast definition that we're ready to offer and defend, but my co-authors can certainly sort of offer their points of view about that. But I think that, I would go back to that paper that we offered with that 4-part distinction, that community does need to move beyond just the setting and a target audience, and really think about how, if we're going to take community engagement seriously, what does that mean to really think beyond these 100, 200, 300 group studies that was very typical of what we found. As I said, I expect that a lot of the day will be taken up by trying to sort of parse and discuss these distinctions between health literacy and health education. I hope it's not purely a definitional exercise, though. I don't want us to sort of chase our tails on that one. I think it's more productive to kind of think about it in light of the third question about what do we bring to the table. How do we take what we have learned over the last 20 to 30 years about health literacy interventions, and how do we make that meaningful to people either thinking that they're doing health literacy interventions, but there's not much elaboration of what that means, or people who don't even say that they're doing health literacy interventions, but it's clear to us by looking at their projects would probably be a lot more impactful if they were looking at health literacy. So with that, I want to conclude, and I believe we're going to have an open discussion period now about the paper. So thank you very much.
Thank you, Cynthia. I'll join you with the table in a moment, but I have a better view of the audience standing here for just a moment.